Here.
Dr. Diana Chapa,
Here.
Dr. David Farmer,
Here.
Dr. Wayne Goodman,
I'm here.
Dr. Hisham Ibrahim,
Here.
Trina Ida, Lee Johnson, Dr. Andy Keller,
Here.
Dr. David Lakey,
I'm here.
Dr. Sarah Martin,
Here.
Dr. Octavio Martinez,
Here.
Dr. Nathan Maxwell, Elizabeth Mayer,
Good morning here.
Dr. Cheryl McCollum Smith, Tara Mitchell,
Here.
Dr. Charles Nemiroff,
Here.
and sorry, it was Dr. Tara Mitchell, I apologize. Dr. Jeffrey Newport, Brittany Nichols,
Here, and Dr. McComb Smith is signing on.
Yep, I'm here. Sorry.
thank you. Dr. Jeffrey Newport. Did I get Dr. Charles Nemiroff?
Here.
Dr. Nikisha Oliphant. Dr. Renee Olvera. Dr. Stephen Pliska. Olga Rodriguez.
Here.
Scott Charles Schlin. Sue Shell. John Scott.
Here.
Dr. Jared Suarez.
Here.
Luann Southern.
Here.
Dr. Carol Tominga.
Yes, I'm here.
Dr. Peter Thompson.
Here.
Dr. Karen Wagner. Dr. Sarah Wakefield. Dr. Patricia Watson.
Here.
And Dr. Laurel Williams.
Here.
Thank you.
How many do we have?
I think 22.
All right, we're at 22. So we're at quorum, so we can go and officially begin. Again, a couple of reminders to folks. Please don't use the chat box. If you do, you have to hear me read them out loud in order for us to be in compliance with the Open Meetings Act. No one wants to hear me read out every message in the chat box. Again, would also request that people keep their video cameras on, the people that are part of the executive committee, and let me know if you're going to leave. Again, I have to make sure that we maintain quorum. And with that, we will go ahead and begin. And as we begin, I want to make a first announcement and let you know that Nagla Ilarian has been chosen to be the next executive director of the Texas Child Mental Health Care Consortium. She has over 30 years of public and population health experience, including 10 years of experience in program implementation and evaluation in Texas in the mental health and substance abuse programs. And she was here as we began this program from the chairs of psychiatry and has been very intimately involved, and so is ready to help us move forward and making sure that we're doing what we need to do to be the good stewards of the funds that have been provided to us. Yeah.
Thank you.
Yay. All right. With that, first item of business, I need an approval of the minutes from the July 15th meeting. If people would take a quick look at that and please give me I need a motion and a second so we can vote on it.
So moved, Ibrahim.
Second.
I have a motion by Dr. Ibrahim, a second by Carol, Dr. Tominga. Any further discussion? Hearing none, all in favor, signify by saying aye.
Aye.
Hi.
Aye. Aye.
Opposed, nay? Anybody abstain? Mark that they were unanimously approved. Next item of business is an update from our internal evaluation team, an update on Salesforce. And Cynthia, I think Cynthia Smith is going to lead us in that update.
Okay. All right, so we're going to be talking about our Salesforce implementation and where we are in the implementation process. Again, my name is Cynthia Smith. I am the Salesforce administrator for the internal evaluation team at UT Austin. I have my email address here on this slide in case you want to reach out if you have any questions about Salesforce that don't get answered during the presentation or during our question and answer time. Okay, our agenda for today, I am going to do a brief overview on Salesforce. I'm also going to talk through user story, which is what helped us sort of frame the vision of Salesforce and how we architected the platform. We'll talk about who all was involved in the project, and then we'll cover a timeline and next steps. We will have time for questions at the end of the presentation. I do ask that you keep a list of the questions that you have and hold off on asking those questions until the very end so that I can get through the slides in a timely manner. Okay, we're gonna go ahead and start off with our Salesforce overview. And so first off, like, what is Salesforce, right? Salesforce is a cloud-based platform that enables businesses to manage relationships with their customers. What that means for us is that if I'm an HRI representative, I might have one spreadsheet that has a list of all my districts in it, another spreadsheet that has all of my schools, and then a third spreadsheet that has all of my contacts. That data is existing, right? But it's living in different places, and so it's siloed. And what Salesforce enables us to do is to put all of that data in one place. And so it really kind of gives you a full 360-degree view of the customer. How will Salesforce be used? The decision was made that since TChat is our biggest program and it has a really large impact, that we would focus phase 1 of our Salesforce implementation on building out TChat functionality. So things like managing enrollment status. Is a school in the planned phase or in the active phase? Are they unresponsive to outreach? We'll be able to manage all of that within Salesforce. Also things like MOU. Does a district have an evergreen MOU or do they have an end date? If they have an end date, we have automation built on the back end that will ping HRI representatives and let them know, hey, this MOU is expiring in 90 days. Please reach out to the district and try to get them to renew. So all of the efforts that we have been focusing on in phase 1 have been around building out TChat functionality. It's also going to be used to replace some of the spreadsheets that HRIs are currently submitting each month to internal evaluation. That doesn't mean the work is going away, right? But what it means is that rather than entering the data in those 3 spreadsheets, instead now I'm entering all of that data in the Salesforce database. Okay, other ways that it's going to be used, Salesforce is going to give HRIs access to real-time data via reports and dashboards that we have built in Salesforce. We do have reports and dashboards pre-built for the team so that when they get in, they can begin using them. What you're seeing on the screen now is a component of a dashboard that's showing pending status by HRI. And what I mean by real-time data is that if I go in and I move a campus from pending to plant or from pending to active, this dashboard component would change, right? So it's based off of the data that's currently in the system. So I think that's going to be really powerful for the HRI reps to have access to that real-time data. The other thing that it's going to help them do is really target their outreach efforts. So if I'm an HRI rep, I might come in on a Monday morning and say, you know what, I'm going to run a report to see all of my schools that are currently unresponsive to outreach. And I'm going to focus my week on contacting those schools. And by the end of the week, I'm going to move them either to declined or I'm moving them to pending. So I really think this is going to help create some efficiencies for the team in terms of outreach for TChat. The other thing that it's going to be able to do is that internal evaluation does get data from TEA. So we know when a school is closing, maybe a school has changed their name. We'll be able to go into Salesforce and make those updates so that the HRIs have the most up-to-date information. What Salesforce will not be doing, I thought it was important to just mention this, it's not going to host any personally identifiable information, what we call PII. It's not going to have any student data in it. It's not going to have any parent data in it. We're not going to have diagnoses in there. That type of information is not going to be contained in Salesforce. It's also not intended to create duplicative work for the HRIs. So as I mentioned, right, they're no longer going to have to submit those spreadsheets. They still have to do the work, but they're going to enter that data in Salesforce instead. And then the final bullet point, it's not, excuse me, replacing Trait. It's going to augment the data that we have from Trait and work together. Okay, this slide is looking at sort of current state versus future state. So phase one, as I mentioned, we made the decision to focus primarily or focus on building out TChat functionalities, so things related to enrollment, MOU status, also those outreach activities. So if I've gone to a school and I've dropped off some swag and I've met with individuals, I can log all of that activity in Salesforce. I can log calls in the system. I can add notes to the system. There's a feature called Chatter, which is similar to Slack or to Teams, where you can mention people on your team and then you can work together. And the great thing about it, again, that it's all in one place. If I'm out of office unexpectedly for a week, other people on my team can open up those records and they can see exactly where that school is standing in terms of TChat enrollment. In terms of a future state, some of these things we've already started working on, others are under consideration. The first item is communications. We have purchased a platform called Marketing Cloud Growth through Salesforce. It's a marketing automation tool that enables us to do email communications and texting. It has been implemented in Salesforce, but it hasn't yet been configured. So it's available to us, but we're not at the place yet where we're going to be using it. But it is really timely that we have Marketing Cloud, because we were notified that Microsoft Dynamics is deprecating their communications tool. And so now UTS will be using Marketing Cloud to communicate with the HRIs. So that is future state, so phase two moving forward. The other thing that we're planning to do is to manage staffing updates in Salesforce. Right now, HRIs fill out a web form that notifies Kosh and UTS whenever they have, let's say, a new hire or someone has left the org. And so moving forward, they would log into Salesforce, they would create a new contact record, they can add in their first name, last name, and then also upload their bio, they can upload their headshot, they can add their credentials, all of those things that we use on the Meet the Teams page for the consortium. All of that will be managed within Salesforce, including FTEs. And then we're also considering provider enrollment for our access programs and CPW monthly reports. Okay. A user story. I thought this would just kind of be helpful for the team to understand how we built the framework for Salesforce. A user story is a general explanation of a software feature that's written from the perspective of the end user. So in our case, the end user is that HRI representative. And so when we built out Salesforce, or when we architected it, we were looking at sort of the work that they do, and we were able to divide it into these three buckets. So the first one is keeping district, school, and contact records up to date. So again, related to TChat. So, is a school in a pending status versus an active status? What notes do you have? Have you had outreach with them? You've logged calls, you've visited them on campus. All of that data can be updated. And what's really nice is that, let's say you're an HRI rep and you have gone to a campus and you've met with a new counselor who seems really excited about TChat. What you can do is when you enter in that contact in Salesforce, that contact doesn't just live alone in the database. They're connected to that school. So you're able to see what all of the relationships are within Salesforce. The second bucket is managing outreach to schools. So again, if I've gone out and I've delivered swag, I can record that. I can log phone calls. I can keep all of that interaction directly within that record in Salesforce. And again, it provides some transparency, right? Because all of that data is in there and your teammates can see that, so you can work collaboratively on moving those schools forward. And then the last one is logging attendance at events. So if I've hosted an event and I had 10 community members attend and 5 parents, I can log that in the system. Again, we're not collecting PII, right? So we're not asking the HRIs to give us the list of the 10 community members or the 5 parents. Instead, what we've done is we've built Salesforce so that we have an attendees section and there's a field for community members, and the HRI rep goes in and adds the number 10, and then under parents, they can add the number 5, and then they can say this was a 30-minute session, this was the topic of discussion, and this is the date that that event was held. So again, just wanted for you guys to understand that when we built out the framework of Salesforce, we were really coming at it through the lens of that HRI rep. All right, project team. So this is who has been involved in the project. I thought it was important just to call this out, that internal evaluation didn't work in a vacuum, right? We collaborated with UTS and with Kosh and with some TChat leaders, met with HRI representatives to talk about their daily work, what are some challenges that they are experiencing, and how can we maybe solve that in Salesforce. And so it wasn't, again, done in a vacuum. We did collaborate with multiple members to get to where we are today. We also did work with the marketing team. There is some light branding that's done in Salesforce. It's not anything crazy, but we do have the logo in there and then the colors, and just wanted to make sure that we were in compliance. We have met with TChat leaders to identify individuals who would be interested in what we're calling our user acceptance testing phase. So have had identified some primary contacts, but we are going to be joining the TChat leadership meeting later this month to get a list of those individuals and talk a little bit more about Salesforce. And then during this process, we've also worked with external partners. So we've met with TEA, we've met with Trait, and then we do also have a consultant who is working with us called Slalom Consulting. It isn't really like a traditional consulting engagement, meaning that they didn't help us with like requirements gathering or architecting the platform. Really what we've used them for is some back-end work, so some custom coding and some development on the back end that I just don't have the skill set for. And so that's how that consulting arrangement has worked out. Okay, this is our timeline. I thought it would be nice to have just a visual representation of where we are in the implementation process. The Salesforce contract was executed and signed mid-June, and then we've used the time from mid-June until now to gather requirements, to build out the TChat functionality within Salesforce. We've had some internal demos just to see like this is how it's shaping up, like what changes can we make. And then we've been working on sample data to import for that user acceptance testing phase. We made the decision to not use dummy data during UAT, or just to have no data at all and have the HRIs just go in and create a fake school or a fake district. The reason for that is because we wanted for the HRI reps who are in the testing phase to really see how like the dashboards and the reports were going to come alive, and then how that is going to look once they get to production. I'm glad that we did this because we've had a lot of challenges with getting the data ready and prepped. And so that will really help us when we get to the point where we're ready to move to production and use current data. All right, so we're at September 16th, which is today. We thought would be a good time to introduce Salesforce to you guys, the executive committee. As I mentioned, we are going to be joining the TChat leadership meeting on September the 27th. Again, the goal for us coming out of that meeting is to get a list of individuals from each HRI who would be joining us for our user acceptance testing. We expect that to begin mid-October, and it should last about 2 weeks. That then takes us into November. So November, December, totally get it, right? We're going to be hitting the holidays. People are going to be going away or having time off. So we're going to be really flexible in that November, December timeframe. But the intention is that we will collect the feedback from that UAT group, make any tweaks or changes to the platform based on that feedback, and then start getting ready to move to production. So right now we're working in the lower environments, what we call a sandbox in Salesforce. So we're not touching the production environment, we're not breaking anything, but doing all the things that we're doing now. And so we do have to prep that metadata, move that over into production. I will tell you, I've been in the Salesforce ecosystem for more than 11 years. Something always breaks when you go from the sandbox to production. So we are going to need to spend some time making sure that that is working properly before loading in the most current data. And then again, in December, that's when we'll pull the most recent data to push into production. Right now, we're working with our like July, August-ish data and things are going to change, right, between now and the end of the year. So we want to make sure that when we do go live, that the most up-to-date information is in the database. We will also be doing some staff training in the month of December. Again, totally get it. People are going to be traveling, so we will offer multiple sessions of the same topic, and we will be recording those sessions. So if someone is unable to attend those training sessions, they can watch the recordings, or if someone has attended the sessions and just wants a refresher, they have access to those recordings as well. And then that will prep us for a go live of January 25. Okay, next steps. So as I mentioned, we're going to be joining the TChat leadership meeting at the end of the month. Again, the idea is that we will come out of that meeting with a list of individuals who are going to join us for our user acceptance testing phase. Right now, we're saying one primary contact from each HRI, but we might have someone who says, hey, listen, I looked at those 3 buckets and I've got 2 people that I want to join in the user acceptance testing phase, and that's okay. But again, the idea is that we go to that meeting and we come out with a list of individuals who are going to join us in the testing phase. After we get that list of individuals, we will then host a kickoff call with them to talk about, this is how you log into Salesforce, this is your username. We will also present them with testing scripts. So testing scripts are just scenarios so that they can have a sheet when they're going into Salesforce, and it'll say, create a new MOU, move the enrollment status from pending to active, create a brand new contact that's related to a school, so things like that. And kind of what we're looking for, we are going to have these testing scripts for them to use as a baseline, but we're really looking for people in the HRIs who are excited about Salesforce, excited about this new platform, who will go in really on their own and just play around, try to break it, right? Let's figure out what's not working in a lower environment before we're moving it into production, because that would really be helpful for my team. And so I'm excited about the acceptance testing phase. And again, that's scheduled to begin mid-October. Okay, all right. Does anyone have any questions regarding the Salesforce implementation?
All right, any questions? We have a little bit of time. All right. I'm not seeing any hands, so you must have laid it out perfectly so everyone could fully comprehend what we're doing. So thank you. If you do have any questions, you had your email address on the first slide, and they can email you and talk to you personally. With that, Rachel, let's go to you. I think the next several things are yours, and so I'll turn the podium over to you.
Okay, thanks, Dr. Lakey.
Mhm.
First item on the agenda is to review our statewide expansion report. As usual, this is data as of July 31st, 2024. So you can see that we are active in just over 70% of all schools, which represents 75% of the student population. So we're covering over 4.1 million lives now.
So just stop there for a minute. Just kind of remarkable. 75% of all kids in the public schools in Texas are now have TChat available. So just another, I think, significant mark. So 4.1 million or 75%. And then when you take into considerations those that have declined because they have existing mental health support, only 15% of the student body now doesn't have TChat available. So again, thank you to all the HRIs for the diligent work to get us to this point.
Here is a proportionate view of status by HRI.
Rachel, I see a hand from Dr. Dominga.
Yes, I wanted to clarify, the black areas at UT Southwestern, that it says 50% are in TChat, and then there's 14 and 21% that we're working with, but that are not engaged. Most of those schools already have some other programs, David. So it would not mean that they're uncovered, but that they're just not covered by TChat. And we can go in, if with a little extra work, we could probably specify how many of those are covered, but we pay attention to them all the time in order to convert them over to TChat.
Yeah, thanks, Carol. That's similar to several other HRIs. We've reached out to many of these many times, and they've declined, or they have services. We're all aware that some of those services may be provided by ARPA funds, and so at some point that may change. But again, thanks, Carol, for all the work to reach out to those. Again, the ones in purple are the ones that are unresponsive, and then the ones in yellow are pending. And so again, a lot of work across the consortium to get to where we are today. Thanks. Dr. Ibrahim?
Yeah, it sounds, Dr. Lecky, it sounds like they figure out funding beyond ARPA for the Dallas district,
Okay,
internal funds to the
Yeah.
district.
good. And again, from the beginning, we've said that, we're not here to push out any other types of services. And if they can have those services through internal funds, that's great. And we celebrate that. But that's allowed us to target on the other schools throughout the state of Texas. Right.
We have, as of July 31st, 481 schools with an onboarding status, and of those, 110 have a planned implementation date. You can see here that most of those were planned for August, so look forward to seeing what next month's report looks like. Here's a view by ESC region. We saw increases in 3 regions this month. Our growth continues on an upward trajectory. Existing mental health providers continues to be the #1 reason for decline. Any questions? I have a verbal update on background checks. So a few months ago, you all voted to implement a new policy on fingerprint-based background checks. Since that time, we have learned about changes to eligibility for access to the DPS criminal history database. And as a result, we did notify TCHAT leaders last month that we would be putting this policy on hold. So we do not expect any HRIs to implement any part of that policy. At this time, we are working with DPS and TEA right now to understand what those changes are and how that will impact our policy. So I will provide another update when we know more. Any questions there? Okay. Next. I'll give an update on our policies, which we are requesting approval from you all, from you all. Let's try again. I will start with the referral and enrollment policy. This was presented the last 2 meetings that we had. Just an overview of key changes. So those underlined are changes that we've made since we met last, based on feedback from you all and HRI staff. So one change that we made to the referral and enrollment policy since we last met was a statement regarding referrals for 3-year-olds. The policy previously had an age limit starting at 4 years old. Since then, we have learned that there are some districts that offer pre-K programs for 3-year-olds. So we wanted to be flexible to meet the needs of those families and those HRIs. So a new statement has been added there about 3-year-olds. And then the following are other key changes, which we went over over the last couple of meetings. Here's a timeline. So after you all approved TChat 2.0, we began policy preparation. We then obtained cautious feedback and reached out to TChat leaders for their feedback. We introduced this to you all, as I mentioned, a couple months ago, and today we would like to request your approval to implement. And of course, Kosh will be available to work with teams on any implementation support.
All right, very good. Can you take the slides down for a second?
Yeah.
So everyone has seen the policy or had the opportunity to see the policy. Rachel has worked with individuals that had questions and concerns, and we've tried to adjust the policy accordingly over this time period. But we want to again bring it to the executive committee and see if there's any other questions. And if not, we can move forward with a formal vote for approval.
Dr. Leakey,
Yes, Olga?
I just wanted to thank Rachel and Dr. Williams for spending some time with us on questions that we had. We appreciate their thoroughness in looking at this and listening to our feedback. So thank you, Rachel and Dr. Williams.
Very good. And thank you for providing your feedback. We want to make sure we get this right. And so again, with any of these policies, if there's questions, let us know, because we want to make sure we get it where everyone feels comfortable with it, the policies that we're putting forth. Any other comments? Hearing none, can I get a motion for approval?
So moved.
Second.
I have a motion by Dr. Thompson and a second by Dr. Suarez. Any further discussion? Hearing none, all in favor of approving this policy signify by saying aye.
Aye.
Okay. All opposed signify by saying nay. Did anybody abstain? Very good. Then let the record show that we got unanimous approval for the policy. And again, our thanks to the executive committee for providing thoughtful input and comments. And as I noted earlier, we want to make sure we get this right. And so thank you for the process and your feedback and the opportunity to approve it. With that, Rachel, let me go back over to you.
Okay, we will move on to the services and discharge policy. Before I move on, just a comment for all of our policies. We do strive to ensure that we're setting minimum expectations that allow for flexibility for all HRIs to implement their programs as they see best fit for their catchment area. So HRIs are always encouraged if you all feel the need to implement institution level policies that augment, or add to complement our consortium level policies. So these are, I'm sorry, this is services and discharge policy. These are key changes to the policy. And again, those underlined are the changes that we've made since we first introduced this to you all at our last meeting. So one change that we've made since last meeting is we did revise our language regarding parental involvement. Again, just to meet HRI needs and expectations for how they involve parents, but did want to set a minimum standard that clinicians should ensure they speak with both parents and guardians and the child as part of the initial assessment. We also did have a statement in the policy about billing not being permitted, and we did want to clarify that that's billing for TChat funded services. We also added a definition for unified care plan that was mentioned in the policy. And we made a correction to the previous version regarding care coordination. Previously, we had made an erroneous statement. So the policy now reads that students and families may require care coordination at any point after enrollment. And then the rest of the bullets listed here, again, are key changes that were shared and discussed at our last meeting. Again, the timeline here, we followed the same process, introduced this to you all last month after getting feedback from Kosh and from HRI leaders in the TCHAT program. And today we're requesting your approval to implement.
Very good. So any comments from anybody or questions? All right, see none. Does anyone want to make a motion?
So moved. Second.
Okay, I think that was Dr. Ibrahim and Dr. Nemiroff. Any further discussion? All right, seeing none, all in favor signify by saying aye.
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 Opposed, nay. Did anyone abstain? Very good. Again, let the record show that we got unanimous approval for this policy. Rachel, back to you.
All right, we'll move on we want to introduce to you all and request your approval to implement a new pilot that we're proposing to increase coordination between our TCHAT program and LMHAs and LBHAs. With the implementation of TCHAT 2.0, you all know that we have introduced intermediate services to our service array. Part of our policy does stipulate that before our HRIs offer a longer term treatment duration, we ask HRIs to ensure they've made a good faith effort to locate available longer term community services. So we know that LMHAs serve children and adolescents who meet requirements for severe emotional disturbance. This is a subset of our TCHAT population. So we feel that there are opportunities to strengthen collaboration between TCHAT and the LMHAs and LBHAs. Last week we did email you all this proposal, and we do propose to implement a pilot in 2 to 3 HRIs, hope to get your approval today to implement that. We prepared the plan in collaboration with Kosh, with internal evaluation, Dr. Pliska, who also helped us form a CPW work group to begin to identify some findings and best practices for collaboration between HRIs and LMHAs. We also received feedback from the Texas Council and the Health and Human Services Commission. As I mentioned, Dr. Pliska formed a CPW work group. They interviewed some HRIs and prepared some findings here, which are also listed in the appendix of our proposal. So you can see that we have a good starting point to help us design our pilot and attempt to understand whether and to what extent perhaps some of these best practices may be implemented across other HRIs. So we will definitely be leveraging these findings again as we work to design the pilot.
Rachel,
Yes.
quick question. I think Danette is still on the call. I was just wondering the feedback from Texas Council, given that historically the LMHAs have been underfunded. So this pilot and this process makes logical sense, right? But how would this work if the LMHAs have traditionally been underfunded?
So, okay, Olga, thank you for the question. First of all, yes, we were very involved in the conversations around this. We really support moving forward with this project. We think we will be informed by, seeing what does the volume actually look like. But we are also heartened to find that there are a number of sites that have already worked through these issues and are managing the referrals quite well. And to this point have not seen a volume that could not be accommodated. So, we'll just have to keep working on this. We certainly don't want to get into a situation in which we have don't have the capacity to manage. But we think it's really important to really understand what that looks like. So as we, work through to get to a more kind of informed way in which the interactions take place between the HRIs and the LMHAs, as we work through finding out, what is the variation from site to site, how much is that driven by local variation, how much of it is driven by resource limitations, and let's think about how we can smooth out variation that's not really necessary to have, figure out ways in which both HRI and the local mental health authorities can work together well, and we can replicate these projects in other areas of the state. We do recognize that there will be resource variation, and we want to know and have a better handle on how much does that actually impact the ability to manage these referrals.
Thank you, Danette. And will the pilot include a rural element as well as urban?
Yes.
Okay. Very good. Thank you.
Here's the timeline that we have proposed. So pending your approval, of course, we would like to move forward with reviewing available data to understand the breadth of this issue, identifying barriers and best practices, which, as I mentioned, we've already begun doing. And then from there, identifying 2 to 3 pilot sites and partner LMHAs. Then getting into the later months of the calendar year, then we'll really start designing the pilot and defining what that workflow from TCHATS to LMHA looks like, and defining our evaluation plan. We'll implement beginning in January through May, and then evaluate the pilot in the summertime so that we have some recommendations available before the beginning of the next school year. Any questions?
Octavio, let's go to you.
Yeah, more of a comment. I think this seems like a logical progression, and I agree with the pilot. However, I do want to put on the record that we continue to work with the state of Texas, obviously, on many workforce issues, and that this doesn't turn out to be by our legislators thinking, "Oh, we've solved that solution," as well as getting to Danette Castle and the question posed earlier about continuing ambulatory and outpatient services, and especially making sure we are funding our LMHAs and our LBHAs appropriately so, because I think that those are synergistic with the Texas Child Mental Health Care Consortium, and not thinking of this, because it goes against really the initial purpose of the consortium, and now we're moving into a different area. Now, will there be an evaluation component to maybe we should be modifying the Texas Child Mental Health Care Consortium and/or providing information for us to then address different initiatives that the state of Texas ought to be addressing when it comes to workforce and/or our ambulatory services?
So I think this doesn't conflict with the mission of the consortium. The challenge is our HRIs are doing TCHAT, and in areas there's no one to hand off the kids to for continued care. And so the goal of this is to get better collaboration between us and the local mental health authorities, who we're already partnering with CPWE and other projects, and to figure out what are those barriers. Maybe they're bureaucratic, barriers, policy barriers, et cetera, that keeps us from being able to efficiently transfer kids over to their care. And so I think we will learn a lot through this and again, figure out what policies may need to be adjusted. From the beginning of putting this in place, it was very important to me that HHSC be very involved, that we identify what policies that they may have and how do we do this. But this is all trying to improve those systems of care so that we aren't siloed between TCHAT and local mental health authorities, that we really are working together. And it doesn't replace the workforce initiatives a lot of us are involved in, or the other workforce issues the consortium is involved in. And so I think that's why this makes sense, and we do it on a small scale and figure out if it works or if it doesn't. And again, I think that's been the opportunity that the legislature has provided us, is that we get to try some things out. And if they work, let's take it to scale. If it doesn't work, let's go in a different direction.
So I think we're on the same page. I just want to make sure we don't lose that.
Yeah.
And then in fact, it is synergistic and not in lieu of. So
Oh, absolutely.
Good to hear.
This is how do we make sure two programs supported by the state work together for the betterment of kids' mental health needs? Okay. Sarah, I see your hand.
Yes, I think this is phenomenal. I'm really, really excited about it. My biggest question is about the choosing of, or maybe not actually even the choosing of sites for the pilot, but there are many different of us working with many different LMHAs across the region, and just wanting to make sure that we are not moving forward, that we're sharing information in real time too about lessons learned, so that we're not waiting until a year from now when we'll be those HRIs that are not involved in the project or in the pilot will necessarily probably continue to work on their relationships with the local mental health authorities in their region. And so I was wondering if at regular TCHAT leadership meetings, this information or what's been learned, what kinds of strategies are being implemented could be shared there as well, so that everyone has the benefit of that pilot information. I worry about us waiting till the end of the pilot to share that data, because there may be redundancies or shared lessons, or we would have to undo that we had just done, or a respective HRI might have just done with an LMHA.
I think that's a good suggestion. I think on top of that, Sarah, I would have this group update the people that are in charge of this group. Dr. Plisko is going to be very involved. Update the executive committee of the Mental Health Care Consortium on a regular basis, just like we do with other projects.
Thank you.
Any other comments? All right. Seeing none, can I get a motion for approval?
So moved.
Second.
Motion by Dr. Tominga, second by Dr. Nemiroff. Any further discussion? Hearing none, all in favor signify by saying aye.
Aye.
Opposed, nay. Did anyone abstain? So let the record show we got unanimous approval to move forward with this pilot. Next on the agenda, we have an update from Dr. Wakefield on PeriPan, and congratulations, Sarah. I think we're at the 1-year anniversary of the statewide rollout. So congratulations.
We are. It's very exciting. So we have a few updates for you. I'm happy to take any questions. Lots of things in the works as well. All right, next slide. So we have continuing to roll along with enrollment, 897 obstetricians, we have 185 OB clinics, 50 women's or maternal health clinics, and 14 midwifery practices. Just as a reminder, because I think sometimes this gets lost in these details, that we are tracking the enrollment of the obstetricians as the targeted metric for increasing enrollment, but PeriPan is offered to pediatricians, family medicine docs, any of those frontline clinicians who are taking care or interacting with women in the pregnant and postpartum period. So these are not the only people that are enrolled in PeriPan. There are many, many, many more people enrolled in PeriPan. But this is the metric that we are tracking, are these obstetricians, because they were brand new clinicians that were not targeted for services in CPAN. Next slide. So as we're excited to show that our consult volume continues to increase. We want it higher and higher, which is why we are working diligently on getting all of the clinicians in our regions enrolled. We continue to see our volume increase, which we're excited about for first-time callers and for those who are calling multiple times. We continue to have the majority of our calls are about specific patients and not just a general question about medical practice. But some of those calls could be for enrollment as well. But the majority of them are for specific patient care. There are a little over half, so almost 70% that also are seeking referral help for the community. How do I get this woman to therapeutic services? What are other services in the region that we could offer her? And then 40%, a little over 40% medication related as well. When we look at who we're trying to refer to, about half are seeking referrals for a local therapist. And then 13% for a local adult psychiatrist, somebody who can provide ongoing medication management in a complex situation. So we're excited that there's a majority of those who are calling for medication-related questions, that the expectation is that care will be retained at the level at which they are being seen right there, which is the goal of our access projects, to retain that care in that frontline clinician as much as possible, build that capacity, and make less appointments, less appointment burden for that woman. All right, next slide. So we like to include, we've gotten this question before about what kinds of, in the donut that we showed on the last slide, what types of physicians are calling in, because it doesn't specify without hovering over there in a live site. We still continue to see that obstetricians are our highest volume of callers at 42%. And then we are working towards, if you look at this third bar, we're working towards the data clarification so that we can know what type of residents or what clinical specialty of the resident who is calling in. But we continue to be really encouraged that 20% of our volume is from resident physicians, meaning our hope is that will translate out in practice as well, that they will carry that skill set with them. And so we're building a generation of clinicians who relies on a access project to improve their capacity and feels comfortable with that relationship. So we're excited about that. And then pediatricians are our second highest call volume. Our family practice doctors are a little bit lower. We do have psychiatrists call in, which we are also excited about. Psychiatrists have questions about how pregnancy or postpartum may be affecting this medication. We're happy to support there so that that woman can be retained in that level of care as well. All right, next slide. So looking at the volume of calls where a psychiatrist has gotten involved versus the volume of calls where a psychiatrist has not gotten involved, so more for resources, referral, some education is when we think of a psychiatrist not getting involved. Medication management questions, diagnostic clarification is typically when we're thinking about a psychiatrist getting involved. So we like to see an upward trend for both of those. In programs across the country, it is expected that about 2/3 of the calls are for resources and referrals, and about 1/3 of the call involve the psychiatrist for that medication management or diagnostic clarification. That seems to be pretty much the case with what we're seeing as our numbers kind of increase and stabilize here. Next slide. So this is our direct consultation slide. This is something that it was fairly complex to get in place across our state. And so there at the beginning was only one HRI that was providing this direct patient consultation service, although they were providing it for all of the HRIs across the state. This is when, as a reminder for everyone and everyone listening, this is when a peri-pan call has happened. The clinician is, that's transferred to a psychiatrist. The psychiatrist is talking with that consulting clinician, and it really is determined that it is too complex or past the comfort level of that frontline clinician to take the next steps in care. So sometimes that's because we have not clarified a diagnosis. The woman is coming in with multiple diagnoses. It's hard to know what to do, but we still think that care can be retained in that frontline clinical setting if we had a clarified diagnosis. Or it could be that even if the diagnosis is clarified, the patient has tried several different interventions, the clinician is feeling, I'm not comfortable continuing that care unless a psychiatrist has done an evaluation and recommended next steps. So these direct patient consultations are this additional step where the patient is seen via telehealth. It requires an abundance more work than answering the phone and talking to that clinician. Each of these is probably about 3 hours plus of work with the initial information, coordination with the patient to establish that time for the appointment, and then the appointment itself. And then the documentation of the appointment, and then finding a time to both create a letter for that primary care clinician or the frontline clinician and getting back in touch with them to discuss those results. So quite time consuming, but we're excited to see that these overall are increasing even during the summer, when we tend to think that people don't seek as much care during that time. So we are excited to watch this increase. We now have more HRIs that are online for providing and direct patient consultations, which is exciting, but we continue to have those sites that are providing those peri-pan direct patient consultations can receive and will and do receive or see those patients on behalf of many HRIs across the state that don't yet have this as a part of their service, and might not ever if they don't have a perinatal psychiatrist there that has the time to do it. So we're excited. This really is building a one team atmosphere across our peri-pan so that we can all work together and address the specific needs of the patient and the consulting clinician. Next slide. So this is our grand round schedule. We continue to have this set for the year. It is almost the end of the year. Feels like this has gone very fast, but this is the third Tuesday of the month, and the noon hour is virtual on a webinar platform. And our next one coming up in just tomorrow is perinatal and postpartum psychosis. We are really excited to be able to offer these. We have attendees from lots of different clinical backgrounds asking great questions, and it is building a community of practice, really, and a community of education around improving our capacity and our understanding of perinatal mental health care. Next slide. That may be it.
Sarah, what's your average attendance on these on those slides
We usually have that slide in there, and we did not have it this time. And so let me see if while we're chatting, Jen Erdigy will send me those numbers. And if not, then I will send them to you directly after this meeting, or tell you in just a second.
Dr. Wakefield?
Yes.
Do you have the data broken out geographically in terms of where are you seeing the not necessarily the highest need, right? But where are the calls and the women being served all over the state, or are they concentrated in certain parts of the state at this time?
Yes, let me, Dr. So it is, we have women calling, clinicians calling from all over the state for sure. We do have some HRIs that tend to get a higher call volume for their region. An interesting thing, because we're all functioning as one team and not every single site has a perinatal psychiatrist, that we have, we can track the number of calls that are coming to the HRI, but that call might actually be responded to by a psychiatrist at another HRI. And so that's really exciting for us because multiple different people can be involved and we can build resources and we can utilize resources where they are and apply them across the state. So that's really exciting. I just have to call out UT Tyler. They are having a great response to their perinatal outreach and enrollment of their clinicians in the area, and continue to really be a superstar in that region for people asking these questions about women, and then UT Southwestern is really helping them with those calls typically, although they can be sent to any HRI. So we do see, it's a little bit of what I'd have to go do, and I think it's a great question for us, maybe at the year mark, although I'd probably like to do it in another 6 months or maybe 2 years, is really look at the difference in population, because sometimes we have HRIs that have they have a high call volume, but it is lower compared to their regional population than another HRI that has a lower call volume, but is higher compared to the regional population. We have not done those, that look yet. I mean, I have my assumptions, I have my thoughts of it when I look at the data, but that's something I think in our upcoming evaluation, and I know the internal evaluation team is listening right now, that we can definitely look at that data and include that, because I think that's interesting to look at the need. For us, it's also a matter of engagement and enrollment with those obstetricians. What we find or at least anecdotally, the feedback that we're getting from our different HRIs is that obstetricians are very busy, although we know that, and hard to catch, and that between an unplanned need to go catch a baby right now, need to run to this thing, that it has been a very different engagement process than our child psychiatry access network, and so I think it's taken us a little bit longer, and we've met a lot of times about strategies to increase that engagement, and so I'd like to look. I think our numbers will be a little bit more stable after some of the implementation things that we're doing right now and over the next 6 weeks or 6 months, that we'll be able to look at that a year from now when we're more than 1 year in, and it be reliable data.
Thank you, Dr. Wakefield.
Dr. Oliphant, I just got a text that my speaker is messing up. Can you guys hear me?
Yeah, it just sounds a little fuzzy. It's like feedback or interference, maybe.
I apologize.
It's okay. So quickly, my question was, now that we are starting to actually take calls from our hub now, we are getting a lot of emergent, like by the time we're reached out to for PeriPan, these patients are in crisis. Like it's almost as if the OBs locally, or who are willing to use the call, are using it as a 911 or a crisis call line more so than an engagement for support. So just curious if that's happening with other hubs, and we're considering looking at, okay, how do we quickly get these women in front of somebody right away, because they are at a point of crisis when the calls come in.
Well, I think it's an interesting question, because I think first we have to really define crisis. Sometimes what we mean by crisis is this moment, this is an emergency, and that woman needs to be taken to the, for emergency evaluation and referral. Sometimes what we mean is, wow, they need a really high level, or they need an assessment very quickly for us to know what to do, so that we know what to do in the next steps, because this could be a crisis very quickly. And I think in that way, that is a great opportunity to talk with that, the perinatal psychiatry clinician, and talk through several things. So if you've not had a chance to look at the website, the PeriPan website, there's the toolkit that exists on the website. There's a safety plan for mom. There's also like a plan to give her before you would need a safety plan. So I call it a self-care plan. That's what we've called it on the website. So there's a self-care plan, there's a safety plan, there's a warning signs sheet that we did about like, what are some typical things that you see after birth? What are some concerning things you see after birth? What are some crisis things that you see after birth? And so really helping provide that education to the clinician, pointing them to those resources so that they can help educate mom. Talking about who's mom's support system, you know, what do we need to do in that case? And so I think, and then how quickly can we get her to a direct assessment or for a direct patient consultation so that we can really clarify how severe this is, are all really important things. But I go back to, we are not a crisis line. We are different than a crisis line. And so if she truly is in an emergency, then we want to provide that information. I never say, this is an emergency, so I can't help you. I say, this is an emergency. You need to refer her to this level of care. Here are some other tools for when she comes back to you. Or here are some other tools that you can give her in addition, and point them to the website and that toolkit with our safety plan, with the self-care plan, with the warning sign sheet, so that they're not left with just send her to the ER, right? There's still education happening in that clinician-to-clinician discussion so that they feel better equipped the next time a patient presents with these symptoms, or better equipped to ask these questions earlier in the care so that it is potentially less likely that mom gets to crisis. Those are all things that I would consider. We don't want to just turn someone away, right? We're here to provide education to increase capacity. And that is an opportunity to provide education to increase capacity. We are also saying you need to activate your emergency services because this mama is an emergency. So I think it depends on what we mean by crisis.
Yeah, like floored psychosis. They call moms in my office actively talking to the wall and believing the baby is not their child. Like floored psychosis.
Yeah. And so for me, I've had that call before. I've had that call to my cell phone before. And I've said, okay, have you gotten mom safe? Have you gotten baby safe? Like is somebody there to support mom? Is somebody there to take baby who mom trusts? Can you call that person so that mom doesn't feel like her baby's being taken from her and it furthers her psychosis, but more feels like, okay, we're all in a care strategy around her. So I think there's still education that can be provided in that, but we're not saying, just do this and then send her home. We're also saying activate your emergency plan. You know, she needs to go to the hospital. This is a really this is a postpartum emergency.
So Sarah, again, thank you for all the work. That buzzing is still continuing when you talk. Just want to let you know that. It doesn't seem to be occurring when some other people talk, but again, thank you for the work that you're doing, and again, congratulations for a year of PeriPan, and actually more than a year, because it's a year of statewide rollout and the year of pilot and the however long we did for planning to get this to where we are today.
Dr. Lakey, I'm sorry about the buzzing. I cannot hear it, but I will try to rearrange things in my office and see if that helps. I do want to say that we average number of webinar attendance has been around 100. We've had around 100 residents. We've had close to 200 obstetricians, 89 physicians, and 33 psychiatrists attend our webinars. So it is a mixed group. That's great, provides rich discussion, but we've had good attendance. Thank you.
Thanks.
All right. Very good. Dr. Williams, let's go to you and for the update from Kosh.
Well, it was kind of a nice couple of weeks, but we've gotten back to it's 95 degrees outside. So hopefully you guys are having a good time out in your neck of the woods in Texas. Next slide. Next slide. So similar to Dr. Wakefield's, we continue to see the volume for our CPAN team increase. We had our highest month ever for August with 1382. So you see that between the volume last year. I'll show you that slide in a second. We have around 1,300 providers and close to almost 40,000 completed consultations. We continue to do very well with calling back within 30 minutes when the provider asks for us to call back, with our median time being about 4.2 minutes across the state. So doing a really great job there for our teams. Next slide. This is what, again, you can see that sort of line across the last couple of years, and we've continued to see growth year to year. We've continued to have steady growth after our sort of normal, usual summer sort of slowdown for child mental health. One of the things that actually was distinct and different for the PeriPan data was PeriPan did not see the summer slump, and we were joking about the fact that babies don't stop being delivered month to month, but children do stop going to school, which is a major stressor for them and their families. So we're glad to see that number continue to rise, and we have an expectation that we will see that number continue to move forward in the next couple of months. Next slide. This is sort of looking down at that breakdown, similar to the PeriPan data. We wanted to very specifically share with you the difference between the total volume of calls, which is at the top at 1382, if you look to that August data point. And within that August data point, 494 of those calls went to our child psychiatrist. And then the other 888 were asking for resources and referrals. And again, this is in line with other sort of state access programs where sort of the proportionality of team members and the involvement of whether they need the full team, both the resource manager and the psychiatrist, or they just need one or the other. So you can see that there we've continued to see overall growth, which we're excited for. Next slide. This is looking very specifically again at that direct patient consultation. So unlike the phone consultation that we were talking about where we provide some education, those calls last anywhere from 10 to 15 minutes. The direct consultation is after that consultation with the pediatrician or family doc or OB. It's felt that there would be some assistance if we were to see the patient. You know, when we get parental permission, we'll see the young person for a one-time visit. That sort of takes about 3 hours time of our psychiatrist because the appointment itself is anywhere from 1.5 to 2 hours long. There's the need to write the report. And then obviously the biggest piece is that call back to that primary care physician to provide not just the letter, but actually the education around the letter and what it said to really help guide, instruct that primary care provider in the next steps for that person. So we're glad to see those numbers continue to rise, and it's definitely making our child psychiatrists across the state increasingly well utilized and busy. Next slide. For our sort of platform to kind of help us keep up to date information, because like I said, you know, 2/3 of our calls are looking for resources and referrals for families and women. So we have the update for our WellNeti platform. This is a real-time platform that allows us to also help each other across the state. So if Baylor's team needed to be offline for some reason, another team is taking over, they will also be able to see all the same resources in our region, still help that primary care clinician provider get the services that they need when it comes to resources. We have a vetting process that allows us to make sure that when we're sending resources for referrals over to a primary care physician, we have the most up-to-date information about that resource. So for example, we know that that resource, because we've called and checked, does take that particular insurance, that it has this amount of wait time until the person could get in. So that way we're helping families and the pediatricians and family docs and OBs who help them have the most accurate information as they go into it. We also will be planning to and use this for TChat as well. Dr. Lakey and others alluded to. We do have a step where we're helping families sometimes after TChat locate resources. So we want to be able to join forces and have some additional efficiencies. So the TChat teams are going to also be onboarded and using WellNeti to find and locate those resources, as well as keep track of them so that we can always be adding to our resource list and refining it in real time. So we will be also hoping to provide some outcome data as far as, how often we're using WellNeti, what kinds of resources are we pulling down from it, and other kinds of aspects of the work that we're doing with WellNeti. And that will be sort of in collaboration with the UT system and IT internal evaluation team to kind of make sure that we get them the data that will help them answer those questions. So we're pretty excited for that. All the CPAN teams PeriPan teams are using it now. And probably in the next 6 to 8 weeks, we will also have the TChat teams be able to use it as well. Next slide. Speaking of the resources and referrals, so again, a big part of what a CPAN or an access program does is provide resources. We're not just talking about a referral to a clinician, we're also talking about vetted resources related to the aspect of care. So let's say the issue is about depression. And so we have created a large data set that sits in the SharePoint site that all the CPAN and PeriPAN teams can utilize. So if I'm talking to a pediatrician and I want to give them a particular paper on ADHD, I can go get that paper out and have our team forward it along. The resources are broken down by, is it for a primary care provider? Is it for a parent? Is it for a patient? If it's for a patient, is it what age of the patient? It has also resources that are not just in English. So we're really trying to do our best to have evidence-based vetted resources, not just the referral piece, but the resources as well. Since we started working on this resource database, we've completed eating disorders, psychosis, anxiety. We're currently working on the next very large topic, which is depression. And we hope that that particular resource group will be done in the next couple of weeks and have that available for all of our teams. And then once that's done, we'll be also collaborating with PeriPAN, Jen Erdrich, Dr. Wakefield to add additional resources specific for women's mental health into the database as well. So we're pretty excited for that. Next slide. One of the things that's happening as we've been talking about with the direct consultations, as we've been working with our data platform vendor Trade to work on the data that we want to kind of input related to the direct consultation process. And so that build is now completed. It's moving into the sandbox in the next week, I think is when it starts to move into sandbox. And we will start to provide the training to all the teams related to the release of this build for direct consultation. So right now, teams are having to do this kind of piecemeal as the build was being complete. The goal is that once this is released, then teams will not have to be doing any double work. They would be putting the data in the Trade system as they would normally do for the other aspects of Trade and CPAN, PeriPAN. And then we will be able to collect that data and then review that data for the evaluative purpose of the team. And also, if we get another call about the same patient in the future, we'll be able to reference what information we shared the last time to make sure that we're not doubling back to recommendations already made, but potentially furthering a recommendation as needed. It'll be all staff training in September of this, so coming weeks, with a go live of the October 7th. So we're pretty excited for this. This did have all the sort of end users involved in the process, the physicians, the behavioral health specialists, and other team members that work to get a direct consult done. As Dr. Wakefield said, there's a lot of moving parts when it's now you're talking about getting a patient scheduled for an appointment. So there's a number of things that sort of happen logistically for teams that we're excited to support them in. And we will be excited to have this build behind us and moving forward. Next slide. Moving on to T-Chat, as you can see here, you have to go to the left. Your eyes might wander to the right, but the left is August. As you can see, we have had, once again, an increase in referrals at the start of the school year than we had even previous year of August. So we've almost hit that sort of 2000 mark. And last year we were at around 1345. This year we're at 1906. Next slide. So from a referral to enrollment, once again, we've also seen some considerable growth with, again, enrollment and referral don't always match up because if referral happens, right at the end of the month, you may still take you several days to talk to the parent and get consent. So they're not one-to-one, but our enrollment of young people after we've had that phone conversation with the parent and they've agreed to the service. We again see a nice looking amount of growth, even in our August at the very start of the school year, with close to 952 parents and legal guardians saying, yes, they would like a service for their young person. So a lot of nice, healthy growth for T-Chat. Next slide. And then this is just sort of that look that's seeing how many service treatment sessions. So after that enrollment process, of course, then we move into providing the actual service. And you can see the care coordination as we started to collect that data in that sort of time frame. you can see the number of care coordination services provided, as well as just the overall treatment sessions. And again, without looking at it in a huge amount of detail, there's obviously growth from year to year. We're getting ready to move to a different look at this slide because we're running out of space. But we'll always have this historical data to show the growth that we've had the last couple of years. Next slide. And again, people frequently ask us, what kind of care is being provided in TChat. And so we consistently are able to say that the majority of the care that's provided is a psychotherapy or a psychosocial intervention with or without case management. And so again, the people that are largely providing our TChat services include our psychologists, LPCs, LCSWs, and a much smaller percentage of them are involved with seeing a physician for a psychiatric evaluation or care. Next slide. So we are in progress for, we had another large release with the trait team and the vendor with sort of how we move patients through that referral process. So that released right as school started. The other thing that we've done, as you're aware, as executive committee, we have agreed that there are some particular outcome measures that we want to provide an opportunity for families and children to complete as we move them through the TChat services. We have created with the UT system a learning center within SharePoint for all of the teams. We have developed short videos by team members across the state from our different HRIs on the different screening measures, along with Dr. Wakefield doing a sort of a primer for everybody understanding the importance of measurement-based care. So we're pretty excited to have that available to all the teams across the state. We continue to provide on-site and virtual support as needed, and that coordination with those HRIs and education support centers that Rachel and Dr. Lakey referenced at the beginning of the presentation this today. And like I said, we'll be working in that implementation of the TChat teams also having access to WellNet and helping us find referral resources as needed. As I said, the things that have launched, one of the things we're really excited about is the family experience survey. We worked with the internal evaluation team to have the trait system be able to automatically send out the end of care service survey for parents and children over the age, I think, of 12. And this will allow the teams not have to do this by sort of manually moving forward. Once a young person service has been archived and the service is complete, the family will be automatically sent out the survey in English or Spanish, depending on their preference. We also have launched the ability to track the number of young people that are coming in that may be doing school through homeschooling processes, as well as the update to the MFA for getting access into the trait system. We will be automating the required assessments beyond the first visit. So right now it's the automation at the first visit, but those subsequent every, I think, third or fourth session, some of the measures, if they're positive, will be automated to go out again. And then obviously we're going to have some abilities for the schools themselves to see some particular aggregated data about their utilization of TChat services, and that will be coming out in August. So pretty excited with a number of the things that we'll be doing to help support operationally the TChat services. And that is, I think, it. Ta-da.
Very good. Thank you, Dr. Williams. Any questions, comments? Luann?
Hi. Hey,
Hey,
Dr. Williams.
welcome back.
Thank you. I have a question for you, Dr. Williams. On the CPAN referrals, is there a way to track how many, or if there are any, referrals that come in from Star Health providers for primary care physicians that are serving children in foster care? I would love to know if there's a way to track that or have the numbers for us over here at DFPS. I'm just curious.
So we do actually ask what insurance the person has. So I do think there's possibly a way to collaborate around that. So we can talk about it a little bit more. But again, one of the things we have to do when we're finding resources is know what insurance a person has. And so I think there's a way for us to work together with you on that.
Okay, because we've been encouraging primary care physicians that are part of that network to utilize CPAN.
for children who have mental health needs and also for education on different mental health topics. So I'm just curious about how they're utilizing it. So that would be great. Thank you.
Very good. Any other questions or comments? All right. Seeing none. Again, Dr. Williams, thank you for your ongoing work with the COSH. Really strong work. One of those data points, Laurel, that I had a little bit of discussion here. The number of enrolled kids this August versus last August, it's almost about twice as many kids enrolled, and so we'll need to see how that plays out over the next several months. So. Could be a very busy year. Again, thank you for everyone for the work that you're doing. With that, I think we're at the end of the agenda. Are there any comments, comments that are germane to the agenda that anybody wants to bring up? All right. Seeing none, I think we're done. I don't think there's anything else we need to bring up. And the next meeting will be 2 months.
Yep.
We'll plan to meet again in 2 months. And in the meantime, we will be working with the legislature on letting them know the needs, that the things that we've discussed here, and making sure that we're representing you well and trying to make sure that the funding needs are understood by the legislature. Several of us will be testifying on Wednesday. Loanne, I think you were there related to this issue with Department of Family Protective Services and the trying to meet the needs of critically ill kids in the state of Texas. And so after that, we will update you. But for today, I think we are done. And again, thanks everyone for being here, and look forward to continuing to work with you. Thank you.
Thank you.
Thank you.
Thank you.